Good afternoon. This is Kristen Santiago. I'm the Director of Strategic Initiatives for C-Change and moderator for today's webinar. Participants of this webinar will have an opportunity to ask questions using the questions function on your screen. The speakers will answer the questions at the end of the webinar. This webinar is being recorded and will be available on the C-Change website, which is cchangetogether.org on Monday. Today's topic is of great interest to C-Change and many others who are on the webinar today. This is a new report that documents and describes that our current cancer care system is in crisis. Hopefully many of you have watched the accompanying video prior to today's webinar, and if you have not, I encourage you to do so. The purpose of this webinar is to educate C-Change members about the new report and its recommendations, encourage further dissemination of the report, and encourage other organizations to work on the recommendations in this report. Today you will be hearing from Laura Levitt, Study Director for this report, and Dr. Patricia Gans, the chair for this report. Laura Levitt, JD, is a program officer at the Institute of Medicine, where she has worked with the Board on Healthcare Services and the National Cancer Policy Forum. Laura started at the Institute of Medicine as a Science and Technology Graduate Fellow in the winter of 2007, and that year received the Institute of Medicine Rookie Award. Laura will be followed by Dr. Patricia Gans, Professor of Medicine at David Geffen School of Medicine and Professor of Health Policy and Management at Jonathan and Carling School of Public Health at UCLA. Dr. Gans is also the Director of the Cancer Prevention and Control Research at Johnson Comprehensive Cancer Center in Los Angeles. Dr. Gans is a medical oncologist and is a pioneer in the assessment of quality of life in cancer patients and has focused much of her clinical experience and research efforts in the areas of breast cancer and its prevention, cancer survivorship and late effects of cancer treatment, cancer in the elderly, and quality of care for cancer patients. Dr. Gans was elected to the Institute of Medicine in 2007 and currently serves as Vice Chair of the Institute of Medicine National Cancer Policy Forum. Following this webinar, C-Change will work with our advisory committees to determine if we should focus on some of the recommendations that are relevant to our strategic initiatives. Some of you may be on this webinar, who are on this webinar may be better suited than C-Change to take up some of these recommendations. So as you hear from our presenters today, please keep in mind whether there is something that your organization can do to act on these recommendations. This Institute of Medicine report is 350 pages, 15 pages long, and has 10 recommendations and 33 sub-recommendations. And our speakers today are going to try and summarize all of those for you in less than an hour. So please give your attention to our first speaker, Laura Levitt.
Thank you, Kristen, and thank all of you for joining the webinar today. It is an honor to present. In this report, the Institute of Medicine presents recommendations to improve the quality of care. The IOM is an independent, nonprofit organization that works outside of government to provide unbiased and evidence-based advice to decision makers and the public. Established in 1970, the IOM is the health arm of the National Academy of Sciences, which was chartered under Abraham Lincoln in 1863. The IOM has received some feedback that this report is very comprehensive, but it's a challenge for organizations to decide where to start or how to work together to implement the recommendations. Thus, we are working with our committee members, C-Change, and other organizations to help disseminate and dissect the information and to provide guidance on how to start addressing the goals of the recommendations in this report. I'm going to review a few background slides. Then please give your attention to Dr. Patricia Gans, who will review the recommendations of this report. Next slide, please. So what prompted our study? The IOM first examined the quality of cancer care in 1999. The report concluded that many patients do not experience high-quality cancer care. Importantly, the study also preceded and informed the IOM's work on the Quality Chasm series, which focused the nation's attention on the quality of health care. Next slide. The 1999 report included 10 recommendations to improve the quality of cancer care. These recommendations were directed at the use of evidence-based guidelines, quality measurement throughout the cancer continuum, and the use of electronic data collection, ensuring that patients have coordinated high-quality cancer care, especially at the end of life, investment in clinical trials and health services research to inform the delivery of cancer care, and improving access to cancer care and reducing disparities in cancer care outcomes. Next slide. In addition to the 1999 report, the work of the IOM's National Cancer Policy Forum also provided input to this consensus study. The forum has convened a number of workshops on topics relevant to the quality of cancer care, including the 3 shown here, on the cancer care workforce, a learning healthcare system for cancer, and most recently, the affordability of cancer care. It also held a workshop on patient-centered treatment planning, which was greatly informative. Next slide. The charge to the committee was to examine opportunities for and challenges to the delivery of high-quality cancer care. Specific issues reviewed included the coordination and organization of care, outcomes reporting and quality metrics, the growing need for survivorship care, palliative care, and family caregiving, rising complexity and cost of care, opportunities for payment reform and new models of cancer care, and the need to address disparities and improve patients' access to high-quality cancer care. Our study is an update to the 1999 report, and it also reflects the changing context in which cancer care is delivered today. There have been tremendous advances in understanding the nature of cancer during the past decade, including the development of many new targeted therapies. At the same time, healthcare reform has changed the context in which healthcare is practiced, and there have been many advances in health IT. Next slide. We are grateful for the 13 sponsors who supported this study. Without them, it could not have been undertaken. Next slide. The report is the work of 17 committee members with a broad range of experience and expertise. The committee included experts in oncology, nursing, geriatrics, internal medicine, palliative care, patient advocacy, economics, ethics, health policy, and law. I would like to especially thank Dr. Gans for her leadership in chairing this committee. Next slide. The central finding of our report is that the cancer care delivery system is in crisis. Our recommendations are made in response to this central concern. Next slide. There are a number of trends amplifying the crisis in cancer care. The aging population is a major contributor to the crisis. The cancer care system is poorly prepared to meet the needs of older adults with cancer. Evidence to guide care decisions for older adults is lacking. This is complicated by the fact older adults often have comorbid medical conditions, as well as the poor coordination of care between cancer care clinicians, other specialists, and primary care clinicians. Fragmentation of care will be exacerbated in the coming decade with anticipated healthcare workforce shortages, which will lead to greater reliance on family caregivers and direct care workers. The cost of cancer care is also rising rapidly, from $72 billion in 2004 to $125 billion in 2010, and it's anticipated to rise to $173 billion by 2020. In addition, the increasing complexity of cancer treatment regimens and their extended duration will stress the system. We also have limited tools for quality improvement. Next slide. My final slides will illustrate some of the stress on the cancer care system of an aging population. Of the 1.6 million people diagnosed with cancer each year, the majority of new diagnoses are in older adults. Next slide. More than 2/3 of cancer deaths are in older adults. Next slide. There are approximately 14 million cancer survivors in the U.S. today. The majority of cancer survivors are older adults. Because of the demographic shift in the population, all of these percentages will increase in the coming decades. Next slide. And this slide shows the projected growth in the number of cancer survivors over the next decade, with 18 million projected in 2022. So given this context, I'm going to turn the webinar over to Dr. Gans, who is going to present the committee's findings and recommendations. Thank you very much.
Thanks, Laura. And again, I'd like to thank Laura for her excellent leadership and support in allowing us to be able to present our recommendations and the report to the community and helping us formulate our strategies regarding this. So could I have the next slide, please? So I'm going to spend a few minutes now talking about a conceptual framework that we developed very early in our deliberations to try and really say, well, what is our vision for a healthcare system that's going to deliver high-quality care and address the crisis that Laura has explained to you. And we think that at the heart of this are engaged patients. But we need a system of healthcare that supports all patients in making informed medical decisions consistent with their needs, values, and preferences in consultation with clinicians who have the expertise in patient-centered communication and shared decision-making. To do this, of course, we need an adequately staffed, trained, and coordinated workforce, and this system must provide competent, trusted, interprofessional cancer care teams who can work with patients across the continuum of cancer and address their needs, values, and preferences. And this has to be also integrated closely with the non-cancer care team as well as the patient's caregivers, and again with the emphasis on older adults who are at high risk to develop cancer. Many of them will have primary caregivers and other specialists who we need to interact with. We need to have an evidence base for cancer care, and we need to depend on this scientific research at the bedside or in the clinic, and we need to have more clinical trials and comparative effectiveness research to help inform our medical decisions. We need to accomplish this in part through a learning healthcare IT system for cancer, which I'll go into more detail about later. But this is a system that would use advancements in information technology to improve the quality of cancer care, patient outcomes, conduct innovative research, quality measurement, and performance improvement. Again, to learn from what's actually going on in healthcare delivery in the cancer sector. We need to then translate this evidence into clinical practice, including quality measurement and implementation of performance improvement. And this system has to rapidly and efficiently incorporate new medical knowledge into clinical practice and clinical practice guidelines. And we need to measure and assess what we're doing so that we can improve on the delivery of care and ultimately publicly report performance information. And we need to develop innovative strategies for further improvement. And finally, our care needs to be accessible and affordable. A system that is accessible to all patients and uses new payment models to align reimbursement to reward patient-centered, high-quality care and eliminate wasteful interventions is what we strive for. Could I have the next slide, please? And here, I think, in this visual, you can see how the patient is at the heart of this conceptual framework, and they are surrounded, of course, by the patients, by the clinicians who will provide care to them. We need an adequate workforce, and again, all of this rests on the evidence base and learning from what we're doing, as well as quality improvement and translation into better quality and affordable care. Next slide. So this is the cancer care continuum, and of course we would like to prevent and reduce the risk of cancer, and there are many interventions that are appropriate in that sphere, but this particular report dealt only with diagnosis going forward and had much to attend to just with that component of the cancer care continuum. In the blue arrow, you can see the elements that the committee felt strongly needed to be part of the cancer care continuum, which included care planning, palliative care from the time of diagnosis, psychosocial support from the time of diagnosis, and prevention and management of long-term and late effects. And along this particular continuum, we need to have family caregiver support because so much of cancer care occurs outside of the healthcare setting. One could also conceptualize these as elements of the acute care process, chronic care, and then end of life in those who will not survive their cancer. Next slide. So this is an overview of the goals of our recommendations, and I'll be going through these in a little bit more detail, but they are very broad, but reflects the conceptual framework that I presented to you. So for example, the goals 1 and 2, providing clinical and cost information to patients in end-of-life care, are part of the engaged patient at the center. And in the last 2, the reducing disparities in access to care and improving affordability, again, relate to the last element in the conceptual framework. Next slide. So what about engaged patients? How can we make this happen? Our goal was that the cancer care team should provide patients and their families with understandable information on their cancer prognosis, treatment benefits and harms, the use of palliative care, psychosocial support, and importantly, with the escalating cost of cancer care, the total and out-of-pocket costs of care, because we know that financial costs are a leading element in bankruptcy for patients with cancer. Next slide. And this is data presented in the report that shows that patients want involvement in these decisions. They want to have their providers tell them the truth about their diagnosis, even though it may be uncomfortable or unpleasant. They want to know about the risks associated with each treatment option, and they want to have an understanding of how the options may affect their quality of life. So meeting the patient and their needs and the level of involvement that they want in their care. Next slide. And this is, again, another model to look at patient-centered care. The committee strongly felt that we need informed, activated, participating patients and their family members to, in fact, deliver this kind of patient-centered care. And again, we have to have an accessible, well-organized, and responsive healthcare system to accomplish this with clinicians who have good communication skills. Next slide. And again, just illustrating here the need for the incorporation of palliative care across the care continuum. Palliative care does not equal end-of-life care. Palliative care is really a focus on symptoms and supporting patients, whether they are receiving curative therapy or are at the end of their life, having their symptoms managed appropriately. Next slide. So recommendation 1 from the report was that the federal government and others should improve the development and dissemination of this critical information, that is, how do we deliver it, using decision aids when possible, that professional educational programs should train clinicians in communication, and that the cancer care team should communicate and personalize this information to their patients, and collaborate with patients to develop care plans that are, again, specific to their particular diagnosis and prognosis, and that CMS and others should design and implement and evaluate innovative payment models that make this feasible. Next slide. Now, what should be the information that should occur in a cancer care plan? There should be information on diagnosis, prognosis, treatment goals, expected response to treatment, treatment benefit and harms, and information on quality of life that the patient would like, as well as addressing the costs and their psychosocial needs. Next slide. This is just an example from a recent New England Journal article. Oh, could you go back to that slide? Showing that, again, the heavy burden of out-of-pocket costs as side effects and the financial toxicity of treatment today for younger and older individuals, not specific to cancer, but in general, and certainly exacerbated by cancer. Next slide. So goal 2 of our engaged patients is in the setting of advanced cancer, whether that occurs at the time of diagnosis or later. The cancer care team should provide patients with end-of-life care consistent with their needs, values, and preferences. Next slide. And that to meet these needs, that there should be professional educational programs that provide training for clinicians in end-of-life communication, that the cancer care team needs to revisit and implement advanced care directives that the patient may have identified earlier in the course of their care, and that cancer care teams need to provide the advanced care patients certainly with palliative care, psychosocial support, and timely referral to hospice and end-of-life care, which is, again, sadly absent in our system today. And to encourage this, CMS and other payers should design, implement, and evaluate innovative payment models. Next slide. So how do we accomplish this? Well, we need an adequately staffed, trained, and coordinated workforce. And again, this means that the cancer care team needs to work collaboratively and with coordination among themselves, but they also need to work with primary care and geriatric physicians as well as specialist care teams to implement the care plans that patients are deciding upon. Next slide. And this just illustrates the complexity and fragmentation of the cancer care team, who are often not co-located, do not speak to each other, and often the patient is the one who's doing the primary communication among all of these individuals. This needs to be changed. Next slide. In addition, the cancer care team needs to work very effectively and efficiently with the others who are caring for these patients. And again, because of the growing number of cancer patients and the limited workforce, we're going to need to work much more smartly and collaboratively among all of the providers taking care of the cancer patient and survivor. Next slide. The recommendation associated with this goal is that federal and state legislative and regulatory bodies should eliminate barriers to scope of practice and reimbursement. That is to say that mid-level providers such as nurse practitioners and physician's assistants should be able to fully practice and be reimbursed, that academic institutions and professional societies should develop interprofessional education programs so we know how to work best with each other, and that Congress should fund the National Workforce Commission, which is part of the Affordable Care Act. Next slide. Again, others are also caring for patients outside of the cancer care healthcare system, and we recommend in this goal that all individuals caring for cancer patients should have appropriate core competencies. Next slide. And again, professional organizations are asked to define core competencies related to cancer, and that cancer care delivery organizations should require that cancer care teams have these core competencies, so that if somebody's on a general surgical ward or a general medical ward, that people are familiar with what the cancer patient needs in that setting, that organizations who are responsible for accreditation, certification, and training, especially of non-oncology clinicians, should promote the development of relevant cancer core competencies as part of the accreditation process, and that HHS and others should fund demonstration projects, especially to provide training to family caregivers and direct care workers who may be providing much of the care for cancer patients and survivors. Next slide. So to accomplish this, we need an evidence base for cancer care, and in this goal, we recommend and look towards the breadth of data that needs to be collected on cancer interventions, particularly in older adults, because most clinical trials do not actively exclude individuals by age, but they exclude individuals who have comorbid conditions such as poor renal function or poor liver function, because they want to have the cleanest population of patients for these trials. Nevertheless, once a drug or a device is approved, it's delivered in a patient population that's much more complex. Next slide. So to accomplish this, our recommendation is that NCI, AHRQ, PCORI and other comparative effectiveness research funders should require researchers evaluating the role of standard and novel interventions and technology used in cancer care to include a plan to study a population that mirrors the age distribution and health risk profile of patients who will actually be receiving this therapy once it is approved. And that Congress, in order to accumulate more information on older individuals and individuals with comorbid conditions, should amend patent law to provide patent extensions of up to 6 months for companies that conduct trials of new cancer treatments in older adults or those with multiple comorbid conditions. This is not to be the primary approval process, but once a drug or a treatment strategy is approved, it should then have a secondary test in these target populations with an extension of patent if appropriate. Next slide. And also that the federal government and, oh, I'm sorry, this is a repeat. Next slide. For Goal 6 and its recommendations, we need to expand the depth of data available for assessing the impact of interventions in patients because we will need this information to design care plans for patients. Next slide. And this recommendation is that the NCI should build on ongoing efforts and work with other federal agencies, PCORI, clinical and health services researchers, and clinicians and patients to develop a common set of data elements that capture the patient experience through patient-reported outcomes, description of relevant patient characteristics, and health behaviors so that we can learn from randomized clinical trials and observational studies how various treatments and disease conditions will affect these patient populations. Next slide. And for Goal 7, in the background, going on to advance our knowledge, we need a learning healthcare IT system for cancer that is developed ethically and soundly, enables us to collect real-time data from the real world to see how our patients are faring in the cancer care that they are receiving in a variety of healthcare settings. Next slide. So the recommendation here is that professional organizations should design and implement the necessary digital infrastructure and analytics, and I think the ASCO Cancer Link experiment is an example of this, and I'm sure there will be others. That HHS should support the development and integration of this system and encourage individuals to participate, and that CMS and other payers should create incentives so that we could rapidly learn from this kind of big data infrastructure how best to treat the patients of the future. Next slide. Goal 8 is, again, a longer-term goal, but one that we think is achievable in the next decade, that we should develop a national quality reporting program for cancer as part of this learning healthcare system. This was indeed a goal of the first quality care report in 1999, which has not yet been achieved. Next slide. And the recommendation here is that HHS should work with professional societies to create and implement a formal long-term strategy for publicly reporting quality measures, again with a focus on outcomes, that they should prioritize, fund, and direct the development of meaningful quality measures. Now the measures that we have in cancer care are very limited and primarily focused on process measures. And that there should be implementation and coordination of a transparent reporting infrastructure so that this can be available to patients, their families, and providers. Next slide. Next slide, please. For Goal 9, we focus on accessible, affordable cancer care, and again, we still have major disparities in access to cancer care, and there are many vulnerable and underserved populations, including the elderly. And we, of course, hope that the Affordable Care Act will influence this with greater access to care, and that is something that we hope to see develop over the next several years. Next slide. Next slide. However, in the meantime, HHS should be serving as a convener to develop a national strategy that leverages existing efforts across the country that are testing innovative programs to improve access to care for these populations, and that when highly effective community interventions are identified, that they should be disseminated and communicated, and there needs to be provision of support for successful existing community interventions. Next slide. And for Goal 10, again, along with the access and affordability of care, we need to improve the affordability of cancer care immediately by leveraging existing efforts to reform payment and eliminate waste. Next slide. And exemplary of this particular recommendation are the Choosing Wisely campaign recommendations, which are looking at things that may be wasteful or potentially harmful, and when they provide no value to patients, should not be offered or should be eliminated. Certainly within Choosing Wisely, there's a recommendation that we have conversations with patients about the lack of value of these types of procedures. And again, ASCO just released another 5, and ASTRO just released their first 5. So there are 15 recommendations now from professional societies identifying areas where we can reduce waste. That CMS and others should develop payment policies that reflect the professional society's findings, that we should not be paying for services that have no or little value, and that CMS and others should design and evaluate new payment models to provide a greater incentive to deliver the kind of quality care that is outlined in this report. And specifically, if new payment models demonstrate increased quality and affordability, that CMS and others should rapidly transition from fee-for-service reimbursement to these new payment models. Next slide. So in conclusion, we hope we've persuaded you that the current U.S. cancer care system, and probably the healthcare system in general, is in crisis, but particularly for cancer because of the aging population, the unsustainable costs, the fragmentation of care. While one could view our report as being highly visionary and not grounded in reality, I think actually many of the recommendations are already being championed by many of the stakeholders, probably some of you who are on this webinar. And we really see this as a blueprint to chart a course going forward and to move the needle in terms of where we need to be. There's a heavy emphasis on affordability and reliance, rather than on the government, but on professional societies and other stakeholders, and I think that's the way we think most of this is going to be accomplished. And again, speaking to you is a great opportunity to share this. But clearly, payment reform and new models of care are going to be necessary in order to accomplish this. So we need to have everyone in the oncology community engaged in this process as it evolves. Thank you very much.
Thank you, Patty. We're now opening up the question and answer portion of this webinar. Please submit your questions using the question box on the bottom right-hand side of the screen, and then we will read the questions out loud. And I'm also going to invite Cheryl Nass from the IOM to join us as well to answer some questions. And Cheryl, I will be unmuting your line. Okay, so our first question is, what is the role for a state or local health department and or public health in general in implementing these recommendations?
I know that there are state cancer plan organizations looking at the whole continuum of cancer care, and to the extent aspects of this can be affected by your organizations, they should certainly be championed. I think, clearly the accessibility and affordability issues, the vulnerable populations, are an area that needs local community solutions. And so I think that's one area of important emphasis, particularly as the ACA rolls out.
Laura or Cheryl, do you have anything to add?
No, I don't have anything to add.
Okay. So we'll move on to the next question. Can you address a bit the issue for rural populations or those where geographic conditions exist, how this might be different?
Laura, do you want to say anything about the telemedicine and some of the things that are in the report in more detail?
I can. The committee does have a section in the workforce chapter on the potential role of telemedicine in reaching rural communities. However, the committee felt that there wasn't a strong evidence base to support making a recommendation on that topic right now. But I think moving forward it might be a solution. And I know that the CMS Innovation Center is exploring models of telemedicine.
I think this is Patty. I think a lot of the other resources, in fact, many of them are web-based. There are actually web and internet-based programs for psychosocial support that organizations such as the Cancer Support Community and others have. And we recognize that people who live in large urban areas often have access to more face-to-face services, either being provided by their healthcare organization or in the community. But I think what we see here is an engaged patient with their provider, wherever they live, can begin to tackle some of these issues in terms of symptom management, if we're talking about palliative care, or psychosocial needs, by finding someone in the community, a social worker, someone who may be able to help with this, but other online and other supports that may be available, even if they're not physically present in the community.
Okay, next question. Are there any existing models of cancer care that you would believe meet the recommendations that were outlined?
I think there are probably areas of the country and programs within individual institutions that probably are touching on a lot of these things, but I'm not sure that any place has it all together. We certainly don't have a rapid learning healthcare system anywhere, and quality improvement strategies are very limited within organizations. So I think the things down the line are real challenging and will need to be developed. But I would again emphasize the physician or provider-patient interaction is something that goes on every day. There are existing communication skills programs. There are ways to enhance the delivery of this kind of care that are accessible today everywhere. So I think, again, they're probably premier examples, but there's terrible fragmentation within oncology and very poor coordination with the external physician community, and that's a general problem.
Cheryl or Laura, any additional comments?
No, I think Patty covered it pretty well.
Okay. Next question. Who do you see as providing training for family caregivers? Could that be nonprofits providing support for survivors and their families?
Or do you want to address that?
Sure. I think it could definitely be nonprofits providing training. The committee just identified a need for pilot testing training methods for caregivers, but I think that various types of organizations could take the lead in piloting different programs.
And I think there was the emphasis on professional organizations identifying what the competencies are, but once those competencies are in fact identified, training could go on in various settings.
Okay, thank you. Next question. Are there any recommendations specific to certain underserved populations? This participant was particularly interested in the experiences of the LGBT community who experience more fragmentation, less access to care, and whose needs and values are less well met at the end of life.
You know, that's an obviously important special community, and I think are vulnerable, you know, to have delays in diagnosis, you know, screening, all of the things that are preemptory to getting a good diagnosis. But we did not specially focus on that community. I would say almost any underserved community has a greater need for the kinds of communication that we're talking about because their needs and preferences may be different from the majority community. We're talking about basic principles of how we deliver care to make it equitable and accessible to everyone.
I would say recommendation 9 in the report is intended to address disparities broadly, but we didn't single out any recommendations to a particular group.
Thank you. How should the federal government address the issues of workforce shortages specifically to meet the needs? I'm sorry, hold on. Okay, sorry. How should federal government address the issue of workforce shortages specifically to the need for adequate skilled workforce to address cancer care?
Well, again, there you saw our recommendation. The ACA did acknowledge the serious workforce shortages that we're going to have across the board in many sectors of the healthcare profession. And, you know, this is in the legislation, but not funded. And so I think we need to really lobby hard that Congress fund this, so at least there can be a critical examination of the needs across sectors and, you know, types of conditions.
I would add also that the committee emphasized the importance of team-based care. So some of the components of high-quality cancer care that the committee identified could be performed by non-physicians, so nurse practitioners or physician assistants.
And also there's a lot of duplication of services. Our current fee-for-service environment encourages patients to be seen by many physicians when maybe 1 or 2 in the cancer care team would be enough. And patients are seen much more frequently than they need to in follow-up as survivors. So eliminating that kind of waste will clearly free up providers to deal with patients who are newly diagnosed and may need their attention.
Can you provide a little more information about how the committee looked at the costs of care?
We actually did not look at the cost of care specifically. Our emphasis was really on quality. So we did not look at cost or efficiency or value. We do think those are obviously very important concepts and factors that need to be examined. Cost was really one of the areas of the crisis. And so our report is more reactive to the cost rather than focus on controlling cost, although our recommendations related to waste and inefficiencies, duplicative efforts, et cetera, inefficiency in delivery of care with duplication of provider services, et cetera, do address the cost issue to some extent. Laura, do you want to say anything else?
Yeah, I guess I would add that affordable cancer care was an important component of the committee's conceptual framework, and that the committee relied heavily on the National Cancer Policy Forum's workshop on affordable cancer care in drafting Recommendation 10, which deals with incentives and eliminating waste, like Patty just mentioned.
We're looking at the cost drivers. Obviously the pharmaceutical costs, the aging of the population, the number of people who are going to be diagnosed, a lot of those. We looked at the cost drivers, but we didn't look so explicitly about how to change that, except for the issues that we talked about in Recommendation 10.
Right. Recommendation 10 really deals with realigning the financial incentives and moving away from fee-for-service.
Thank you. That was the final question that came in online. Patty, Laura, or Cheryl, do either of you have any final comments before I provide my final comments?
Well, I think, we hope that you will have a chance to view the slides offline and perhaps can share them, and certainly the video with others in your organization. We have been working very hard to disseminate the findings of the report. There are some publications that are being presented in various journals that highlight various aspects of the report, and we can certainly provide C-Change with a list of those publications so that people may want to read more condensed versions than the whole report. And also, if we can be of help to you as you disseminate this in your organization, we'd be happy to do that. We being mainly, I'm relying on the IOM.
Yeah, I would just echo Patty and say that we're very excited that C-Change and its membership is interested in taking the lead on implementing or disseminating some of these recommendations. And the IOM is here if there's something we can do to support those efforts.
Thank you. And I would like to take this opportunity first to thank the Institute of Medicine for putting together this report, and to Laura and the rest of the IOM staff, and Patty, Dr. Gans, for taking the time to provide the slides and be on this webinar today. I would like to point out that C-Change's work in core competency development and patient navigation and in disparities was mentioned in this report, which was we were very thankful that the Institute of Medicine recognized the work that we're doing, and I would like to thank our members who are on this webinar who helped us in those efforts. The purpose of us holding this webinar was really to increase awareness of this body of work and spread the word about this report, and we really ask that everyone on this webinar work with your own constituents to further disseminate this report and the accompanying video. C-Change, as I mentioned at the beginning of the webinar, will be discussing these recommendations with our advisory committees to really identify the pieces that we can act on. And I encourage that everyone on this webinar does the same thing and works with your organization and your membership. Take a look at what you work on a daily basis and think about what you and your organization can do to act on the recommendations in this report. And we really hope that you keep the dialogue open and share with us the pieces that you decide to work on. So this does conclude today's webinar. If you have any remaining questions, please email them to me at kcoxsantiago@cchangetogether.org, and I will work with our presenters to answer them. The slides and a recording of this webinar will be posted on our website on Monday, so you'll have access to this information. And finally, I would like to thank the presenters one more time for sharing your insights and your dedication to these issues. This is something that's very important to C-Change and to our membership, and we're really happy that we have you on our side working on these issues.